I'm Peter Block in Anaheim, California at the AHA annual meeting, and this is a wrap-up for day number 1. To my left is Deepak Bhatt from the Brigham and Women's in Boston, and to my way far left, almost out of the picture, is Kim Eagle from the University of Michigan. So there are 3 trials we want to talk about at this first day: PRESERVE, Bruise Control, and TRICS-3. And I'm going to talk a little bit about PRESERVE to start with, since I've got the mic in my hand.
Absolutely.
And I've got control. So this is a trial for acetylcysteine versus sodium bicarb versus sodium chloride and so forth. And acetylcysteine finally gets pulled off the shelf and we can throw it away. At least I hope so. So Deepak, give me a quick run on this trial.
Yeah, I'm a big believer in it. It is an important question whether to use these different renal protection strategies that small studies published in high-tier journals said were effective. They've gone into widespread use worldwide, and now a definitive trial has shown no benefit of N-acetylcysteine or sodium bicarb. So just stick with prehydration with saline, try to minimize the volume of contrast.
You know, I do this a little differently. I actually, before the patient sees any contrast, check their LVED, and if it's in the normal or low range, I will push that up to high normal, simply to give them volume so the kidneys start to diurese before they see any contrast. I don't know if that's the right or wrong thing. Maybe that's another trial, but there you have it.
It was a trial, the Poseidon trial.
Oh, okay, and that showed, did it work?
Yeah, it worked.
So give it at the front end.
Yeah, measure the LVDP, use that to titrate volume.
So why did we use acetylcysteine still?
Because, you know, there's an initial very positive small trial published in a high-tier journal, and, you know, then it impacts practice. People keep doing it.
Truth has nothing to do with randomized trials,
I
or,
don't know about that.
vice versa.
Peter, I thought this was a really good trial, the 2x2 factorial design with sodium bicarb versus just saline, and then an acetylcysteine. Everybody got about a liter of fluid, and absolutely no signal at all of benefit from N-acetylcysteine. And we've been doing this how long? Thinking it worked.
Years and years
It's got to be a
But
decade or more.
The fact is, I don't think a liter is enough for some folks. This is why I mentioned the LVED business.
Yeah, I think you're right.
I agree with you. Also got to credit the VA for doing this trial, answering these important questions in a several thousand patient study.
All right, moving on, bruise control. Deepak, it's all yours.
Sure, so this was a nice study. It was, I think, also very informative. Took patients undergoing EP procedures and randomized them either to continuation of NOAC or interruption of NOAC. And, you know, it wasn't a lot of events, but within the context of what statistical power they had, it seemed you could basically go with either strategy. No harm, no foul with either approach, either in terms of ischemic or thromboembolic events or bleeding events. So if you choose to continue the DOAC for the EP procedure, this study would support that. If you want to interrupt, the study supports that too.
This is a nice follow-up of Bruise Control 1, where they looked at the question, should you continue warfarin or not, suggesting that continuation of warfarin was safe. I like this trial a lot because there are certain patients who have a very high thromboembolic risk, where you say, you know what, I think I want to continue the agent. And there are also those at high bleeding risk, peripheral vascular disease, maybe the very elderly, where you say, you know, I think I want to interrupt. And the risk of stroke and or major bleeding was identical in both arms. So it really gives clinicians freedom to make a good choice based on the individual patient.
And we know that patients who are, you know, have high CHA2DS2-VASc scores and high risk for thromboembolism, if you stop the anticoagulation, they get into trouble.
Absolutely.
With thromboemboli,
Yeah.
I should say, yeah. So I think that's a good trial for all kinds of reasons.
Absolutely, it gives the operator some freedom to use discretion. I like it.
All right, let's move on. TRICS-3. So, Kim, it comes to you. The transfusion after cardiac surgery. Should you or should you not transfuse at what level of hemoglobin?
Yeah, this has been a challenge for us for years. You know, how low do you let the hemoglobin drop after a bypass operation or a major cardiac operation before you transfuse? This is a randomized trial of 5,000 patients. And an aggressive cut point was transfusing at 9.5, a hemoglobin of 9.5, versus a more restricted at 7.5. And absolutely no difference in overall event rates, one bit. So this really, I think, helps us understand that we don't need to transfuse patients until their hemoglobin drops typically below 8 to 7.5. And we all know that blood transfusions carry their own risks. They can affect immunity, increasing the risk of postoperative infection. So I think this is a practice-changing trial.
And blood transfusions carry a long-term risk too, which is not immaterial. I mean, we have to remember that. They're not good for you. On the other hand, Kim, you and I argued a little about this before we started all this business about, well, your patient's got a hemoglobin of 7 and he's not doing so well, and do you really want to give 2 or 3 units of blood to make them better? And you said, give them some volume instead. You still really believe that, Kim?
So this study says if their hemoglobin's 7.5 or higher, I can replete their volume without it being blood, and it's probably safer.
Yeah, I
Probably
agree.
safer.
It changed my mind.
Yeah,
Good.
there's also the cost implications too, right? Blood's an expensive resource, sometimes a scarce resource, so probably don't want to really transfuse unless there's a good reason. And this trial says there's not a good reason.
Any last words about any of the trials? What do you think of those 3 as the most important?
Well, I think PRESERVE sort of puts the nail in the coffin of N-acetylcysteine once and for all, and we really needed the trial to do that.
Yeah.
And I think the TRICS-3 is a big study that really does change the game in terms of when you transfuse. Our EP colleagues are going to be happy with bruise control because it's been debated whether we should stop or continue the NOACs.
So I ask you, which of the 3 are the most important? You said all 3?
Yeah, it depends on the patient, Peter.
There you go.
Like always.
You know,
All
I
right.
like his diplomatic answers. That was pretty good.
Yeah, I thought that was pretty good
I don't
too.
think I could do better than that answer.
From Anaheim, California, thanks a lot, folks.